Most people who are managing high blood pressure are doing everything they have been told to do. They are taking their medication. They are watching their sodium intake. They are trying to exercise more. And their blood pressure is still not where it needs to be. Or it is controlled on paper, but the underlying vascular health, the actual condition of the arteries and the heart, continues to quietly deteriorating in ways that a blood pressure reading alone does not capture. I want to talk about why that happens. And I want to talk about a 10-minute daily habit that addresses something most blood pressure management strategies completely miss. Not a supplement, not a dietary change. A specific type of breathing practice that has been studied extensively in peer-reviewed clinical research and that produces measurable, documented reductions in blood pressure through mechanisms that are entirely distinct from anything a medication does, which means it does not replace medication. It works alongside it. And in many cases, it addresses the physiological drivers of high blood pressure that medication cannot fully reach. I am Dr. Julian Cross. I work in emergency medicine, and high blood pressure is one of the most common and most consequential conditions I encounter. Not because it is dramatic in its early presentation, it almost never is, but because of what it does silently over years to the heart, the kidneys, the brain, and the blood vessels before anyone fully appreciates the damage that has accumulated. The nickname silent killer is not dramatic exaggeration. It is an accurate description of how hypertension operates. And one of the most important things I have learned from watching patients manage this condition over many years is that the standard advice, less salt, more exercise, take your medication, addresses some of the picture, but consistently leaves one of the most powerful drivers of elevated blood pressure almost entirely unaddressed. That driver is the autonomic nervous system. Specifically, the chronic imbalance between its two branches that develops in the majority of people with sustained hypertension. Understanding this is the key to understanding why the 10-minute practice I am going to describe works as well as the research shows it does. So let me walk you through the physiology before we get to the practice itself, because without the mechanism, the benefit will not make complete sense. Your autonomic nervous system controls all the functions of your body that operate without conscious input. Your heart rate, the contraction of your blood vessels, your digestive function, your immune response. It has two branches that operate in dynamic balance. The sympathetic branch drives activation, the fight or flight response, increasing heart rate, constricting blood vessels, raising blood pressure, mobilizing energy. The parasympathetic branch drives restoration, the rest and digest state, slowing heart rate, relaxing blood vessels, reducing blood pressure, supporting cellular repair. In a healthy, young cardiovascular system, these two branches balance each other continuously. Sympathetic activation rises when demand rises. Parasympathetic tone rises when demand falls. Blood pressure fluctuates appropriately in response to real demands and returns to a healthy baseline when those demands pass. But in the majority of adults over 60, particularly those with established hypertension, this balance is chronically disrupted. The sympathetic branch is persistently overactive. The parasympathetic branch is chronically suppressed, and blood pressure is not responding dynamically to real demands anymore. It is being held elevated by a nervous system that has lost its ability to fully downregulate. This is not simply stress in the ordinary sense of the word. It is a deeply embedded physiological state driven by years of accumulated chronic stress, disrupted sleep, sedentary behavior, inflammation, and the progressive decline in autonomic flexibility that occurs with aging. And here is why this matters for blood pressure management. Antihypertensive medications work primarily on the downstream consequences of this autonomic imbalance. They block the effects of elevated sympathetic signaling on the heart and blood vessels, or they reduce blood volume to lower the mechanical load. They are effective at what they do, but they do not address the upstream autonomic dysfunction driving the problem. The nervous system continues to generate the excessive sympathetic output. The medication continues to blunt its effects, and the underlying imbalance persists. What the research on slow, deliberate breathing has demonstrated over the past 2 decades is that this practice directly targets the autonomic nervous system itself. It measurably shifts the balance between sympathetic and parasympathetic activity in a direction that produces real reductions in blood pressure through mechanisms that are fundamentally different from any pharmacological approach. The practice is this: 10 minutes of slow-paced breathing at a rate of approximately 5 to 6 breath cycles per minute. That translates to an inhalation of roughly 4 to 5 seconds, followed by an exhalation of roughly 5 to 6 seconds. Slightly longer exhalation than inhalation. Done once daily, consistently. That is the entire intervention. And the research behind it is substantial enough that I want to walk through the key mechanisms in detail, because understanding them changes how you experience the practice. Instead of doing a breathing exercise, you begin to understand that you are directly intervening on the physiological systems driving your blood pressure. The first mechanism is baroreflex sensitization. Your baroreflex is one of the most important short-term blood pressure regulation systems in your body. Baroreceptors are specialized pressure-sensing neurons located primarily in the walls of the carotid arteries and the aorta. They continuously monitor blood pressure and send signals to the brain to make rapid adjustments. When blood pressure rises, the baroreflex triggers responses that bring it back down. When it drops, the baroreflex triggers responses that bring it back up. It is a continuous feedback loop designed to keep blood pressure within a healthy range. In people with hypertension and in older adults generally, the sensitivity of this baroreflex system declines. The baroreceptors become less responsive. The feedback loop becomes sluggish, and blood pressure regulation becomes less precise, more variable, and persistently elevated as a result. Slow-paced breathing at 5 to 6 breaths per minute naturally synchronizes the breathing cycle with the natural oscillations in heart rate and blood pressure that the cardiovascular system produces. This synchronization, which researchers call respiratory sinus arrhythmia when it involves heart rate, amplifies the signals being processed by the baroreflex, and over time, measurably increases its sensitivity. The feedback loop becomes more responsive, blood pressure regulation becomes more precise, and resting blood pressure comes down as the system regains its ability to modulate cardiovascular function efficiently. A study published in the journal Hypertension examined the effects of slow-paced breathing practice on baroreflex sensitivity in hypertensive patients and found significant improvements after just 8 weeks of daily practice. The improvements in baroreflex sensitivity were directly correlated with the reductions in resting blood pressure observed in the same patients. This is not a coincidence. It is a direct expression of the mechanism. The second mechanism is vagal tone enhancement. The vagus nerve is the primary highway of your parasympathetic nervous system. It runs from your brainstem down through your chest and into your abdomen, innervating your heart, your lungs, your digestive organs, and more. When vagal tone is high, your parasympathetic nervous system is effectively dominant. Heart rate is lower, blood vessels are more relaxed, blood pressure is lower, inflammation is reduced. When vagal tone is low, your sympathetic nervous system is relatively dominant, and all of those parameters move in the opposite direction. In people with hypertension, vagal tone is almost universally reduced compared to individuals with normal blood pressure. This is both a consequence of chronic sympathetic overdrive and a contributor to it. The reduction in vagal tone removes the primary brake on cardiovascular activation, and the sympathetic nervous system operates with less opposition. Slow, deliberate exhalation is the most direct behavioral stimulus for vagal activation available without medical intervention. During exhalation, the vagus nerve transmits signals to the sinoatrial node, the heart's natural pacemaker, that slow the heart rate. This is why heart rate drops slightly with each exhalation and rises slightly with each inhalation. That rhythm, called heart rate variability, is a direct marker of vagal tone. Higher heart rate variability means higher vagal tone, means more robust parasympathetic nervous system activity. When you practice slow-paced breathing with an extended exhalation, you are deliberately and repeatedly stimulating vagal activity for the full duration of the practice. Research using heart rate variability analysis has shown that this practice produces acute increases in vagal tone during the session, and with consistent daily practice, produces lasting improvements in resting vagal tone that persist throughout the day. The parasympathetic nervous system becomes chronically more active. The sympathetic branch becomes chronically less dominant, and resting blood pressure reflects that shift. The third mechanism operates at the level of the blood vessels themselves. Endothelial function. The endothelium is the single-cell layer lining every blood vessel in your body. It is not passive structural tissue. It is metabolically active, producing compounds that regulate vessel tone, blood clotting, and inflammation. The most important of these compounds for blood pressure is nitric oxide. Nitric oxide causes smooth muscle in vessel walls to relax, dilating the vessel and reducing vascular resistance. Lower vascular resistance means lower blood pressure for any given cardiac output. Endothelial production of nitric oxide is exquisitely sensitive to two things: shear stress, which is the mechanical force of blood flowing along the vessel wall, and oxidative stress and inflammation, which impair the enzyme that produces nitric oxide. Slow-paced breathing influences both. The rhythmic changes in intrathoracic pressure created by slow, deep breathing alter venous return to the heart and create cyclical changes in cardiac output and blood flow velocity that increase the shear stress signal, promoting nitric oxide production. Simultaneously, the parasympathetic dominance produced by this practice reduces systemic inflammation and oxidative stress that would otherwise suppress endothelial nitric oxide synthesis. The result is improved endothelial function and greater vasodilatory capacity. Vessels that were chronically constricted by both sympathetic overdrive and endothelial dysfunction begin to relax and dilate more efficiently. Research published in the American Journal of Hypertension found that slow-paced breathing practice improved endothelial function as measured by flow-mediated dilation in hypertensive patients, and that this improvement was associated with reductions in both systolic and diastolic blood pressure. The vascular effects of this practice are not imaginary, and they are not simply the result of relaxation. They are the product of specific biomechanical and biochemical changes in the vessel wall, driven by the altered pressure dynamics and autonomic balance that slow breathing creates. Now, let me address the clinical evidence directly, because I think the magnitude of the effect documented in the research is something most people are not aware of. A meta-analysis published in the Journal of Human Hypertension pooled the results of multiple randomized controlled trials examining the effect of slow-paced breathing on blood pressure in hypertensive patients. The pooled analysis found mean reductions of approximately 8 millimeters of mercury in systolic blood pressure and approximately 5 millimeters of mercury in diastolic blood pressure associated with regular slow breathing practice. For context, many commonly prescribed antihypertensive medications in standard doses produce reductions in the range of 8 to 10 millimeters of mercury systolic. The effect size of this practice is genuinely comparable to pharmacological intervention in many studies. Not in every patient and not in every context, but the magnitude is real and it is clinically meaningful. To put those numbers in human terms, a sustained reduction of 5 millimeters of mercury in diastolic blood pressure is associated in large population studies with approximately 34% reduction in the risk of stroke and approximately 21% reduction in the risk of coronary heart disease. These are not small numbers. They represent real reductions in the probability of the events that end or permanently diminish lives, and they are achievable through 10 minutes of daily breathing practice done correctly and consistently. Let me now walk through exactly how to do this correctly, because there are several elements of technique that significantly affect whether the practice produces the physiological outcomes I have described, or whether it produces a diluted version of those effects. Find a position that allows your chest and abdomen to expand freely. Sitting in a chair with good upright posture works well. Lying on your back also works and has the advantage of making abdominal movement easier to feel. The specific position matters less than the consistency and the freedom of breathing movement. Do not do this practice in a position that compresses your abdomen or restricts chest expansion. A slouched position on a couch, for example, limits diaphragmatic movement and reduces the intrathoracic pressure changes that drive many of the mechanisms I described. Begin by simply breathing normally for 30 seconds to a minute. Do not immediately try to impose a slow rhythm. Let your body settle. Then begin to gradually slow your inhalation to approximately 4 to 5 seconds. Feel your abdomen rise first, before your chest. This is diaphragmatic breathing, and it is important. Breathing that uses primarily the upper chest and minimal diaphragmatic movement does not produce the same intrathoracic pressure changes that drive baroreflex sensitization and venous return modulation. Diaphragmatic breathing, where the belly moves outward first as the diaphragm descends, generates the full range of intrathoracic pressure change that makes this practice physiologically effective. Then allow the exhalation to be slightly longer than the inhalation, approximately 5 to 6 seconds. The exhalation does not need to be forced or complete. A natural, relaxed release is more effective than a deliberately emptied breath, because forced exhalation activates accessory breathing muscles that introduce sympathetic activity and partially counteract the vagal stimulation you are trying to produce. Think of the exhalation as releasing, not pushing. Natural, slow, and slightly extended beyond your normal exhalation length. At this pace, you should be completing approximately 5 to 6 full breath cycles per minute. If you find this pace uncomfortable because it feels too slow, do not force it. Start with a pace that feels slightly slower than normal, but not uncomfortable, perhaps 7 or 8 breaths per minute, and gradually over days and weeks, work toward the 5 to 6 per minute target. The practice is most effective at that pace because it most closely matches the natural resonant frequency of cardiovascular oscillation, the rate at which the baroreflex and heart rate variability oscillations naturally cycle. But an uncomfortable, forced practice is less effective than a comfortable practice at a slightly higher rate, because discomfort introduces sympathetic activation that partially negates the parasympathetic effects you are working to produce. 10 minutes, once daily. The research is fairly consistent that 10 minutes produces meaningful effects, and that longer sessions do not produce dramatically larger benefits. Once daily appears to be sufficient for the autonomic retraining effects to accumulate over time. What matters far more than session length or frequency is consistency. Daily practice produces progressive improvements in baroreflex sensitivity, vagal tone, and endothelial function that build on each other over weeks. Sporadic practice produces acute effects during the session that do not accumulate into the lasting physiological changes the research documents. If you practice for 3 days and then skip 4, you are largely resetting your starting point each week. If you practice daily for 8 weeks, you are producing a meaningfully different autonomic baseline than the one you started with. Timing matters less than most people think. Morning practice has the advantage of occurring when sympathetic activity is naturally highest due to the cortisol awakening response I described in other contexts, which means the parasympathetic input of the practice is introduced at the moment of peak sympathetic dominance. That timing may have particular benefit for the morning blood pressure surge that is associated with elevated cardiovascular event risk in the early hours. But evening practice also has documented benefit and has the practical advantage for many people of fitting more naturally into a consistent routine. The most important timing consideration is simply that you do it at the same time each day, because consistency of scheduling is the most reliable predictor of whether a daily habit actually becomes daily. There are a few situations where I want to add clinical context before you begin this practice. If you are currently on antihypertensive medication and you begin this practice consistently, you may see your blood pressure come down to levels that are lower than your current medication targets. That is a good problem to have, but it does mean you should be monitoring your blood pressure regularly and discussing any significant downward trends with the physician managing your medication, because your dosing may need to be reassessed. Do not adjust or discontinue medication independently based on blood pressure changes you observe. Bring the data to your doctor and have that conversation. If you have a history of respiratory conditions, such as severe COPD or significant sleep apnea, these conditions can affect your ability to regulate breathing during the practice, and your physician should know you are incorporating it. For the majority of adults with hypertension, in the absence of significant pulmonary disease, this practice is safe, has no documented adverse effects at the pace and duration described, and carries none of the side effect risks associated with pharmacological intervention. I also want to be honest about what this practice does not do. It does not eliminate the need for dietary changes in people whose blood pressure is significantly driven by sodium intake. It does not substitute for physical activity, which produces its own distinct and complementary set of cardiovascular adaptations. It does not address secondary causes of hypertension, such as kidney disease, thyroid dysfunction, or sleep apnea that require specific medical evaluation and management. And for individuals with severe hypertension, systolic blood pressure consistently above 180 or diastolic consistently above 110, it is not a first-line intervention. That degree of elevation requires prompt medical management, and this practice, while still potentially beneficial, is not the priority in that clinical context. What it does do, for the majority of adults over 60 with primary hypertension or blood pressure that sits in the elevated or stage 1 or stage 2 range, is provide a clinically validated, mechanistically grounded, completely accessible daily practice that addresses the autonomic nervous system dysfunction driving their blood pressure in a way that nothing else in their current management plan is addressing. 10 minutes, no equipment, no cost, no side effects, and a body of peer-reviewed evidence supporting its efficacy that is more robust than the evidence behind many interventions that receive far more attention. The cardiovascular events I see in the emergency department, the strokes, the heart attacks, the hypertensive crises, are almost never surprises to the cardiovascular system that experiences them. They are the end point of a process that has been building for years. Blood pressure that was elevated for a decade, arteries that became progressively stiffer and less responsive, an autonomic nervous system that ran in chronic sympathetic overdrive until the accumulated damage reached a threshold that produced an acute event. The window for intervention is long. It is open right now for the vast majority of people watching this, and the interventions that matter most are not the dramatic ones made in response to a crisis. They are the consistent daily habits maintained over years that keep the system from reaching that threshold in the first place. 10 minutes every day, same time, diaphragmatic breathing, 4 to 5 seconds in, 5 to 6 seconds out, 5 to 6 cycles per minute, consistently for weeks and months. That is the habit. That is the evidence. And that is what your autonomic nervous system, your baroreflex, your vagus nerve, and your endothelium actually need from you every single morning to work the way they were designed to work. I am Dr. Julian Cross. If this kind of mechanistic clinical explanation is useful to you, please subscribe and leave a like. I cover cardiovascular health, metabolic disease, and long-term physical resilience from an emergency medicine perspective. The kind of content that tells you why, not just what.